Hello, today we can have a look at nummular dermatitis and also its variant, the one we call oid disease. And as you can see in this picture, we see someone having a copper coin-shaped lesions that are a little bit eczematous, erythematous, and as well as a little bit scaly. So this is how nummular dermatitis will look like. And it has gotten different names depending on the literature you're reading. Some literature, they call it nummular eczema. Some literature, they call it discoid eczema, and in other literature, they call it microbial eczema. So the key features that we usually look for if you are to make a diagnosis of nummular eczema include the copper coin-shaped or disseminated eczematous lesions, which are usually very, very pruritic, and oftentimes they have a chronic cause. They are very hard and recalcitrant to treatment. That is one of their actually key features. So when you look at nummular eczema, it is one of the uncommon forms of eczema with a coin-shaped lesions. Clinically, it can occur in patients with atopic dermatitis, steatotic eczema, and then also as well as stasis dermatitis. So you have to be very keen to make a distinction if it is occurring in atopic dermatitis, because in some cases, that's when you make a diagnosis, maybe of atopic dermatitis with nummular morphology, and that is actually different from the nummular dermatitis. So there's actually a contention up to date where they are thinking that nummular dermatitis may actually not be its own entity, but just maybe a morphological presentation of these other eczemas. So even up to now, now I'm discussing it as an entity, but the literature will tell you that the entity is not yet well differentiated from the other causes of eczema. So when you look at the prevalence may range from 0.1 to 9%, depending on how someone actually distinguishes this copper or coin-shaped lesions from other types of eczema. So you may find that most of the researchers will say that maybe this is atopic dermatitis with nummular morphology, so that makes the prevalence to be low. Someone says that maybe it is just an independent entity, then the prevalence may be slightly higher. So oftentimes men are affected more than women, and typically it can occur for ages above 50 years, and women are a little bit affected at a younger age. So in women, the typical lesions are seen below 30, but for men, the lesions are seen a little bit late after 50 years. So when you look at the associated factors, these ones include contact sensitization, xerosis, and then venous hypertension, like the stasis that gives us the stasis dermatitis that also ends up presenting with a nummular morphology or the nummular dermatitis. So 3.5% of the patients with eczema in a study where the diagnosis was made with nummular dermatitis, only 32.5% of these showed a positive patch test reaction, commonly to either to nickel, potassium dichromate, or even cobalt chloride. So now here in this study, it simply shows you that at first you're thinking that maybe, oh, this is maybe nummular dermatitis. But then when you go ahead and try and see maybe if there's any history of contact dermatitis, and then you do the patch testing, you find that now some of the patients were actually sensitive to maybe these other allergens like the nickel and then the potassium dichromate down within cement or even cobalt chloride. So that means that in this case, 32% of the patients were actually misdiagnosed. So meaning that if you are to look at nummular dermatitis as a separate entity, maybe a morphological presentation of the other eczemas. So, and then there's no clinical or laboratory signs of atrophy in the true nummular dermatitis. That's what they're trying to think. But we may find that these features of atrophy may not be there, but now the patient has features of maybe allergic contact dermatitis. So if you are to look at the clinical features, we see round or discoid patches, mainly seen on the extremities. Women commonly have theirs on the forearms and the dorsal aspects of the hands, whereas men commonly have them on the lower legs. And the size of lesions can vary from 1 to 2 centimeters in diameter or even larger in some occasions. And the presentation can either be acute inflammation with vesicles, weeping, or even sometimes can present as a chronic lichenification with hyperkeratosis. So most times it has very, very intense pruritus. So the patient will have a lot of excoriations, which can be punctate or even linear in nature. And the cause is oftentimes chronic with a very resistant form that we call the oid disease. So these two gentlemen, that is Salzberg and Jeb, try to describe a syndrome or a variant of nummular dermatitis that they called oid disease. So oid comes from two words. For the first one, the first oid is that these rashes or these eruptions are usually lichenoid, and then they are also so that is the first oid, and then they are also discoid, meaning that they are round or they are what, they are nummular in appearance. So that is the second oid. So that is the disease we called oid disease, just simply meaning discoid lichenoid rash or eruption on the skin. So that is the variant of nummular eczema that is very, very tricky when it comes to treatment, very resistant, and oftentimes it may need you to actually give even intralesional steroids. So this is how nummular eczema will look like. These discoid lesions are well demarcated, eczematous, peli, and erythematous as well. So when you go to pathology, it also falls under the category of eczema. I know that in eczema, you get a spongiotic type of pathology where you have marked spongiosis. That means that you have intercellular edema with parakeratosis because you're having a high rate of turnover. So you have retained nuclei in the stratum corneum. And then this can also be accompanied by lymphocytic infiltrate, especially in the dermis, and as well as you can also see a degree of edema in the upper part of the dermis, in the papillary dermis. So if you are to zoom in this histology picture that you see here, so you see this is our stratum corneum, and then you see that you have cells that have retained their nuclei. So that's what we call the parakeratosis. And then when you go to when you go to the epidermis, the other layers, you see that the epidermis is also a bit thick, which we call acanthosis. And this is the lichenification that comes with the nummular dermatitis. And you see that in between the cells, we have these whitish spaces, and that is water or intercellular water, and that or edema, and that's what we call the spongiosis. And when you go down here, you see this infiltration of lymphocytes that are there within these layers of the skin, and this is how the histology will look like. And in this case, you see there's loss of the stratum corneum. This reddishness that is the cell crust. Sometimes this is even blood, like you see here. This is blood. This signifies the excoriations and the trauma that goes to the skin as someone tries to scratch this lesion. So that's how the pathology will look like in nummular dermatitis or nummular eczema. So when it comes to diagnosis, as I've told you earlier, there's still a debate ongoing, trying to distinguish nummular dermatitis from other eczema or other causes of eczema. And you find sometimes can be a little bit challenging because nummular eczema can be a manifestation of atopic dermatitis, contact dermatitis, or even stasis dermatitis. And you have to distinguish it actually from psoriasis, Bowen disease, mycosis fungoides, as well as tinea corporis, especially the tinea incognito, whereby patients have used different corticosteroids, which can change the morphology of the rash. And in terms of treatment, these are the lesions that you want to give either your medium or high potent corticosteroids. And sometimes you can try tacrolimus or imiprodimance, and then you have to moisturize the skin with a lot of emollient. And then sometimes, if the lesion is too much oozing and it is weeping, you may end up trying to use astringents like pink potassium permanganate solution, as well as you can use the GV paint, which also have antibiotic effect. And you know that in this case, these lesions can be super infected with bacteria, which again progress or trigger more inflammation and making it a little bit recalcitrant. And we've gotten some few cases where these lesions were actually superimposed with fungi, and it was actually very hard to treat until when you had to give an antifungal, which eliminated the fungus, then the lesions eventually cleared. And then in other treatment options, you can also do phototherapy in cases where it is very resistant, And in this case, you may need to use maybe the handheld phototherapy devices, which directly give the phototherapy to the affected area rather than giving a full body exposure. Because in this case, the lesions are usually discrete, located on only localized parts of the body. So thank you very much. That was the session on nummular eczema, and see you in the next video. Remember to share, subscribe, and disseminate information.